if you want the best care for you, work with your physician, agree on an outcome, and then be involved. So on the back of your insurance card or look up online, there's a number. Call that number, right? I'm a customer. This is what I've agreed on with my physician, and push the issue. If you call and push the issue, a lot of times they'll give you an authorization number and you can help get that pushed through.
Welcome to In Good Company, elder care in your backyard.
Dr. Curtis Mattson brings a rare blend of clinical insight and executive leadership to every conversation. With advanced degrees in both psychology and business, Dr. Mattson serves as the administrative director of the Cardiovascular service line at CoxHealth, where he bridges the gap between human behavior and healthcare operations. A past president of the Missouri Psychological Association and former adjunct professor at Missouri State University, he brings a grounded, compassionate perspective on how people and systems thrive together. Dr. Mattson, welcome to our show.
Yeah, thanks for having me.
Welcome.
I'm excited. That was, wow, I don't get that good of an introduction when I walk through at home after the end of the day at work. So that's great. Took a little creative license with the introduction. I appreciate that.
So tell me about your current role. What's your day-to-day like?
Yeah, so day-to-day is, one of those jobs where every day is different, but also every day has a little bit of that commonality of being the same. So in hospital administration, particularly in the cardiovascular service line, so we are charged with really anything that has to do with your heart and the vascular system of the body. So we take care of a wide range of people, lots of different ages, but most of our patient care tends to be really 55 and up. Although, again, we're seeing issues with cardiovascular health start to become ever younger and younger problems. And so we are seeing that as well. But for the most part, my job focuses on really hitting a few key things. So number one, my big passion is providing access. So my goal is to everyone in Southwest Missouri, Northern Arkansas, Northwest Arkansas, Northeast Oklahoma, I want to make sure that if they need cardiology care, if they need vascular care, if they need a cardiac procedure, that we have a way to get them in. It's a little bit unreasonable, right? I mean, there's a reason there's other hospitals in Joplin. We have competition, here in Springfield with Mercy, but we need all of those systems to be great too, because in truth, we can't realistically provide care for every person that lives within a 300-mile radius of Springfield. But that doesn't stop that from being my goal. And so we want to make sure that if you need care, we can get you in. Our goal shouldn't be that if you need care, you have to wait 6 months to get it, a year to get it. If you have an issue with your heart, we want to make sure that we get you in as quickly as possible. So that's probably the primary thing that I spend my time with my leadership team focusing on. And then secondly is really what I would say is like care innovation. So I work with a lot of our physicians on how do we create or bring new procedures to the area. So there are some new procedures. We just had some press releases recently on what's called a TAMBI procedure, which is a vascular procedure. And don't ask me to describe what it is. I still don't know that I know all the details. But again, it's the physicians and I have a great relationship. They know where this stuff is. They know how to research it, how to get information. They will then bring that back, work with me, work with our procedural team in the actual labs and the ORs. But I really look at my goal as facilitating the physicians to think outside the box as to what's out there that we're not doing that we can bring to the area. Procedures like that allow us to offer a new service to people that usually would have had to have driven, to Kansas City, St. Louis, Little Rock to get those sorts of things. We can now do those here. And so along with innovation, kind of thinking about what is the next iteration of healthcare look like. I think part of that, what we need to be prepared for is the proliferation of virtual care. I think you're going to see over the next few years an expansion of not just, historically, virtual care was, you got on the phone or a video with somebody, and we call that synchronous care, right? You're doing it at the same time. I think you're going to see an expansion of asynchronous care, which is a fancy way of saying you would call and leave a message or a video message for the provider. The provider would then basically record or answer that at a later time. Almost like right now, you send a message through the portal to a physician and they reply back at a later time, except it maybe even being done virtually. I think if you combine that with, as the electronic health records get more sophisticated, I think you'll see integration of like smartwatches, smart rings. I think you're going to even start seeing a proliferation of like the different glasses that have the smart systems built into them. And I think you're going to see some of that information as well start to automatically feed its way into the electronic health record.
So potentially a live feed for patients.
I mean, yeah. I mean, think about it. If you're a patient, and again, you guys like opinions, I'm going to give you an opinion. As a psychologist, as a healthcare administrator, I love people. I want to make sure people get help. People in general are not the most reliable historians when it comes to their own behavior. And so, when we ask people, how's your exercise been? Oh, okay. Well, maybe they'll say good. Well, they're thinking, well, yesterday I was up playing with the kids, and I mowed the lawn this weekend. So yeah, it's been pretty good. But if you were to take a 1 month look back at that person's lifestyle, you might notice that 28 of the 30 days, they have been almost completely inactive, and they had 2 days of activity. And maybe, again, from a psychology standpoint, right, recency bias and primacy bias and all these other things, you think, well, in the last few days, I feel like I've been active, so it's been good. All of this to say, instead of asking you that question, the physician pulls up your chart and there's a day-to-day feed of your smartwatch results of your number of steps and your heart rate monitoring and everything else. You could not only track what was their activity actually like, but you could also see, all right, hey, it looks like your heart rate was really elevated on this day for a majority of the day. Oh, well, we went to Silver City and we walked around up the hills all day and I got a whole bunch of stuff. Okay, well, that's explainable. But what if you didn't do that? What if you were just sitting around the house and your heart rate was really elevated all day long? Well, we need to look into that, right? And so I think you're going to see this proliferation of kind of advanced virtual and really kind of technology related care. And so I look at my role as being one to kind of help innovate with that, because I have my leadership team that does a lot of day-to-day functioning of the actual clinics. So I look at my role at an elevated level as, are there things out there that we can take advantage of, work with the managers, the physicians to, bring new things in. And so that's the second. And the third is the boring one that no one really likes to talk too much about, but it's really the financial responsibility, right? And it's understanding the climate of healthcare when insurance companies are paying less and the cost of care is going up. It's a really difficult time for financial or for the financial standing of healthcare, and the kind of boring Excel spreadsheet part of my job is making sure that we stay on top of that. So that's a really long answer to what my day looks like, but those are really the three things I fill my day with. So
wow, there's a lot to unpack in all of that, and I don't even know where to start exactly. But let me just circle back to, when you talk about bringing in innovation, you've got providers, and what's the process? I mean, is there a whiteboard or something, and you're with your clinicians and you're like, okay, what are we wanting to chase down? And from an administrator standpoint, you're like, okay, we've got to train clinicians, we've got to get equipment, we've got to have a sales component. We've got to figure out if we can get paid for this. Like, walk me through some of that.
So for the most part, in truth, a lot of the industry reps do a lot of that background work for us. And what I mean by that is they're developing these new technologies. They're, taking them to trials. They're working on getting FDA approval. For the most part, they work on getting, CPT codes, which is our billing codes, built, right? So as much as we want to innovate in healthcare, we can't bring something new to the environment without FDA approval and without billing codes for it. And so a lot of times when industry reps will bring us these things, whether it's a new type of catheter for heart procedures, or a new procedure like the TAMBI procedure, when they bring that to us, usually they've got a lot of the technology worked out. They've got a lot of the FDA human trials, and they've got FDA approval. And so for us, it's a combination of looking at here's what they want for the equipment and, for the ability to do this procedure. Does that actually fit into what our patient population looks like? So if it's a new procedure that's, being developed for a very specific disease state, there likely will be a lot of research we have to do on our end about what does our patient panel look like. Do we run into this issue? Is this new procedure fixing what we used to have to do 3 procedures for? If so, would that actually save us money? And then looking at what are the outcomes, right? So if we do this procedure, what's the risk that we're going to have to either redo it or do something later to fix it? And then what is it going to take to get our people trained? So we have to factor all that in. And usually when we look at these sorts of equations, we're looking at kind of what's our return on investment. So we know that right off the bat, if we've got to spend a bunch of money up front for new power generators or whatever that may be, we know that there's going to be that initial loss, but over what period of time are we going to make that up? Sometimes we add new procedures because it's the right thing to do, and ultimately it's roughly a break even, but it's something that no one else in the area is doing, or if they are not doing a lot of it and we have a chance to really become an area market leader in that. Sometimes we do it because it's the right thing to do to keep our patients from driving 3-4 hours to do it. So I think a lot of misconception about healthcare is, oh, we added this new procedure because we're going to make $1 billion a year on it. Honestly, most of our surgical procedures are relatively break even. I mean, we have a few that we do make money on, but most of our procedures actually have pretty slim margins. And so between the costs that we have to pay for all the equipment, the training that we have to get for everybody, the staff that it takes to do whatever thing that is that we're doing, the insurance denials, the pre-certs that come along with, I mean, there are so many failure points in the chain to actually go from potential patient to completed surgery that the total break even for a lot of these procedures isn't that big of a margin.
How challenging is the insurance? I know that's changing a lot, especially over the last decade. And
so, honest opinion, insurance is probably the biggest challenge that we have in healthcare, at least is the way that I see it. So, if, like, for example, if we're having a person come in for a procedure, we, for the most part, there are a few insurances we don't have to, usually kind of standard Medicare and things like that allow some surgical procedures without pre-certification. But, and I'm sure some of my friends that work in the insurance side of the organization are going to listen to this and be like, he doesn't have no clue what he's talking about. So I'm just going to give you my perception of it. But in truth, it's, if you're coming in for that procedure, and let's say, because we usually don't schedule a lot of surgical procedures months and months and months out, right? Because any data that we get today that tells us, yes, this procedure is needed, and then we schedule you 3 months out, we have to have multiple checks usually before that procedure, because if the arithmetic has changed, right, then we've got to revisit our process. So, if we're going to schedule, so if we were to see somebody today on a Tuesday and schedule your procedure for next Monday, That gives us essentially at this time, 3 more days this week, and then Monday to have your insurance company pre-certify or approve that procedure. Right now, that really requires us to either submit information through an online portal or to really expedite things to call. And if that insurance carrier does not have enough people to answer the phones and they don't answer, or they don't pre-cert their online portals fast enough, you may get to the day of that procedure and there's no approval. So that procedure gets canceled.
Wow.
And so when that procedure gets canceled and there's now a hole in the schedule, we're paying, most of the physicians get paid on some sort of version of an RVU, which is basically the work they do gets paid out. But the cost that it takes to keep the lab open or the OR open, or the cost that it takes to keep the nursing staff and the tech staff there to keep the lab or the OR open, that's just empty time that costs us money to have that running. So that's a big issue. Even if we get something pre-certed and we do the procedure and then we bill that procedure, if we don't use the right diagnosis code, it'll get denied. So part of the issue is insurance companies generally don't pay, or they will reduce payment for unspecified diagnosis codes. And in medicine, I think it's, again, some of my physician friends may fight me on this, but in medicine, I think it's a little bit easier to get a more certain diagnosis. So, if you diagnose someone with diabetes unspecified, there's probably other tests you could have run to clarify, is it, with this or with that or, or whatever. But I think back to my days as a psychologist. If somebody came in to see me for the first visit and I needed to bill that visit out in order to get paid, I would have to essentially come up with a diagnosis. And so if I see you and I'm seeing you for the very first session for 50 minutes and I'm trying to get your entire history or as much as I can in that 50 minutes, and I diagnose, say I diagnose depression not otherwise specified, I don't get paid for that. And so in order to get paid, I have to essentially say, this is major depression, right? Or this is, generalized anxiety disorder. Well, that may or may not end up being the right diagnosis, but asking someone who's trying to get your work history, your medical history, your family history, and then create a diagnosis for you in 50 minutes and have it be accurate, to me, that's a little bit misleading to the patient. And so the same thing kind of happens in healthcare is, if we're meeting a patient for the first time and we diagnose, again, diabetes unspecified or chest pain unspecified, it likely won't get paid. And so there's a lot more that goes into that diagnosis, usually in the form, at least in cardiology, of additional imaging tests or stress tests or things like that, that will allow us to refine that diagnosis. On the procedural or on the surgical side, if when they have to indicate, what particular area of the heart or what particular, vein or whatever it is that they did, and they, they list the wrong letter or number or whatever it is that tells kind of what area they were in, it gets denied. And so then we have to either redo it or go back and check documentation. And luckily we've got teams trying to make sure this stuff doesn't get incorrectly, placed on the charge list. But in the rare chance that does happen, we then go back and we fix it. And luckily, right, the issue isn't that we did the wrong thing. It's that it just got documented with the wrong number, the wrong, whatever it was. But, those are the kinds of things. Any one of those failure points can cause the insurance to get denied. And then insurance companies have anywhere from 30 to 60, sometimes 90 days to reply to a bill. So when we send that bill out, we may not know whether that bill is going to be paid for 2 months. Then once we get it back, if it was denied and we want to appeal it, now we're going 2 months back in the medical record to get the documentation and check it. And if we find, hey, we didn't do this, and I'm just making this example, but we didn't do this review of systems. And it's like, well, yeah, I did. I noted on here that everything was fine, no issue. But you actually have to spell it out and say review of systems, whatever. Well, if they go back and addend that note and say, review of systems fine, it may not be accepted. And so now you've got this whole thing that isn't paid. So ultimately we make decisions on getting patients the right care, and we deal with the insurance piece on the back end. But insurance makes it very, very difficult to make sure that we collect on everything that we do.
It's hard in a podcast like this because we keep circling back with guests over and over and over again about how clinicians are tripping over insurance. And, one of the biggest complaints that we hear on a regular basis from clinicians is that, and it's hard for us to gauge the full impact of it, but delay of care, having to jump through hoops and make sure you're saying just the right thing, having to pick a diagnosis way early, sometimes before a clinician's really ready to make a decision about that because of the way the billing system is set up. And, money, as boring as it is, we can't do any of this without money.
Right.
And so those are the things that we want to try to bring to the surface to the general public, is that healthcare has really been hamstrung in some ways. And unfortunately, what we have noticed too is that it's guiding healthcare in a direction. And sometimes clinicians will complain about this. They're like, it's like I wanted to go right, and the insurance company said I had to go all the way around and do these other things before I could do what I know is the right thing to do for this patient.
Yep.
Do you have clinicians that complain to you about things like that?
Yeah, no, we have, like every other service line or every other specialty, we have a range of patient care issues where our physicians are recommending a route. And insurance, again, whether it's you can't do this until you have this imaging done, you can't have this until you have this, test done. It does delay that. And so that's definitely a problem. What I always tell people is, we certainly want them to listen to their physician and to be active participants in their healthcare. A lot of people don't spend time to call their insurance company. If you want the right care that you want, right? I mean, we do a lot where we talk about, we have conversations with patients to make sure, do you understand this procedure? Do you want to proceed, right? We try and uphold the patient's values, what they want, what they think is the best thing for them. What I try and tell people is, if you want the best care for you, work with your physician, agree on an outcome, and then be involved. So on the back of your insurance card or look up online, there's a number. Call that number, right? I'm a customer. This is what I've agreed on with my physician, and push the issue. Again, it doesn't mean that it's just going to be, whatever you want, we'll just roll out a blank check and you can have whatever you want. But if you are waiting on a hospital system with thousands of patients that are trying to get pre-certed, or an insurance company that will sometimes be in short staffing situations where they can't respond to pre-certification issues quickly, and it's a procedure you want, pick up the phone. If you call and push the issue, a lot of times they'll give you an authorization number and you can help get that pushed through. And so whether it's with that, with other things, but yeah, I think we definitely have physicians that feel the pinch of that. And I think the best way to work through it as a patient would be to really take an active role in what that care looks like.
As healthcare providers, there's a piece of me that feels like, how do we empower people more and in a more formalized way as a system, saying, how do we give people support to be able to deal with the insurance company that may or may not already want to disqualify somebody from a procedure or whatever, and they need to know the magic words, because if you don't code it right, you're not going to get paid. But if you don't say the right things as a patient when you're trying to advocate for yourself, you're definitely not going to get that authorization.
The best way that I would probably describe it would be, we need a system that's set up where you have to opt out instead of a system that we have right now where you have to essentially opt in, right? So and what I mean by that is, when you need a procedure, it's almost like the system is set up to say, no, you don't, unless you prove all the reasons why you do. We need a system that I think is set up that says, your doctor says you need a procedure, so you're going to get it unless we start to get compelling evidence that you don't. So again, to your point with, home health care, you're going to get home health care unless there's a tremendous reason why you shouldn't. And again, if you're like, well, I do the push mower by myself every day for 4 hours a day, you probably don't need home health care.
Right.
But I took the walker, or I used the whatever to get outside, and I got on the riding mower and I steered myself around the yard to be in the sunshine for 30 minutes yesterday. That should not disqualify you from anything.
Yeah.
Like, I can think of very few things that 30 minutes outside on a riding mower should disqualify you from for care. And so I think that's the system right now, is it's set up where everyone is opted out and they have to almost be opted in. Right. And I think we need to reverse that, where you're opted in unless you opt out. And if your doctor tells you need the procedure, it's almost like you need to be the one that says, no, I'm not going to get it, for you to not have access to it. Yeah. But that's not the system that we have right now. And I know too, and I'm not in these exam rooms, but I've heard providers complain about like annual Medicare checks, and I don't know if this is just an indication of the EHR that we use, or if this is part of the Medicare. So please take this with a grain of salt. But I've heard providers complain about issues like, if you have a patient who is an amputee, that every year when you redo their paperwork, you have to continuously mark amputee, because every year it resets. And so like if they had a below knee amputation on the left side, and they come in for their annual the next year, and you don't mark below knee amputation on the left side, and then you try and bill something as a amputation with complication, it'll get denied.
Wow.
Even though it's bit like,
yes,
that again, that's that you're opted out until you get opted in, as opposed to when you have an irreversible condition, you are unless we're over here regrowing limbs, but if you have a amputation below the knee, it ain't coming back. Like, you shouldn't have to redo that every year. And then if you forget to do it, all of a sudden you're not getting paid as the physician. That's an overly, I think, onerous impact that we're putting on the physicians to do that level of paperwork when it's something that is an irreversible condition.
Are you looking at technologies like AI to check these errors, to kind of look over that work just to make sure these mistakes don't happen?
I think that's where you're going to see as the electronic health records get more and more sophisticated. I think you'll see, the health records have things like problem lists and, medication lists and things like that. And where it may be a condition that's, permanent, is automatically re-updated every year, so you don't have to recheck the box. But ones that aren't, can be checked or unchecked. Moving to the ICD-10 that we have now, we essentially diagnose kind of what the presenting issue is. So it's possible, as you have kind of transient diagnoses that kind of come and go with severity, you can kind of move them up and down on the problem list. So it's not like 10 years ago, this was the number one problem and it will always be the number one problem. If it's not a permanent thing, you can kind of move it down. So I'm seeing the patient today for this, and this is the presenting problem they're here for, but these things also exist. So if you see someone in cardiology, that may be the number one diagnosis. They might also have a nephrologist or something like that they see the week after. The nephrologist might say, well, the issue I'm seeing them for is this. And so that's kind of the new number one diagnosis on the charge sheet. So I think things like that have helped us with the billing and the charging to be more accurate. But yeah, I think you're going to see advancements in the EHR systems allow for that to happen. Hopefully, because I mean, right now it's a manual review process and very tedious. So
we just had somebody on recently that came from a cancer clinic, and they talked a lot about, some of the things that people would potentially ignore and wait too long to come in to get seen, or that there was in some cases there may have not been training in the general practitioner realm where things were getting flagged soon enough and that sort of thing. Are there things in cardiology that you feel like are maybe signs and symptoms that people are ignoring too much, or potentially those general practitioners are not referring out enough that you're having to constantly kind of go back and re-campaign for?
Yeah, I think all in all, I think our general family practice doctors, internal medicine doctors do a great job. There's a lot that they're asked to be responsible for. And so, having to know a lot about a lot, right? It's one thing to know a lot about a little or a little about a lot, but they have to know a lot about a lot. And so, if anything, I think our goal in my service line would be to have a closer relationship with them. I've kind of talked to my team a little bit about almost as like a kind of discussion or consultation kind of super highway, right? How do we get directly from physician to physician to kind of just check some of this out? But I think they do a great job. As far as things that I think people put off, cardiology is one of those really interesting things because of the relationship between mental health and heart health. And so when you're looking at the relationship between mental health conditions and things like blood pressure, things like tachycardia, the pace or, atrial fibrillation, different ways that, anxiety can manifest versus cardiac conditions can manifest. We have a significant number of people every year that come into the emergency department complaining of chest pain. And it's really when the evaluations are done, right? They've had the imaging, they've had all the different tests. We've taken labs, we've evaluated everything. There's nothing really indicative of a cardiac issue. And yet these individuals are still complaining of chest pain. Well, from a psychological standpoint, you look at what are the physical symptoms of anxiety, and it's, fatigue, chest pain. I mean, so we get a lot of individuals that may mistake a cardiac issue for what's really an anxiety issue, whether it's acute or long-term anxiety issues. And I think that's what people need to be aware of is, similarly, if they've gone a good portion of their life and never had a diagnosed anxiety issue, and all of a sudden they start having some of those chest pain issues, don't just write it off as, oh, that must just be anxiety. If you've never had that issue, don't assume it's a brand new flare up of that. Get it checked out first. If you come back and you find out there's nothing to indicate that it's a cardiac issue, okay, there's lots of other treatment resources for that too. Mm-hmm. But if you write it off and it was a cardiac issue, all the time you delay that care, right? I mean, your heart's this muscle that never stops. The longer you let it work inefficiently or incorrectly or with something being wrong, the harder it is to kind of fix that problem down the road.
Is there an avenue for self-referral in the cardiac system?
Yeah. So usually with like general cardiology, that's possible. When it gets into subspecialties like electrophysiology, we usually then require a referral because it's even kind of a niche within cardiology below. But yeah, we empower people to do that. And, looking at technology, for better or worse, I think patients are going to get a lot more involved in their own diagnosis.
Yeah.
And I think the stigma around the worst part of that discussion is kind of that historical, WebMD, right? It's, you talk to someone at a dinner party and, they either have, the common cold or throat cancer. They don't know which one it is, but they're probably going to die next week. And, it's like, okay, thanks WebMD, like, cause, for doing that. But the real innovation, I think, with technology is going to be with the artificial intelligence. And in fact, I think what you're going to see is, and I think very observant physicians are appreciative. But the great thing about technology is, again, sources of power aside, it doesn't rest. It doesn't need a vacation. It doesn't take a holiday. And so the nice thing is, the practical implementation of medicine, when you plug those symptoms, and if you have lab values or imaging test results, and you put that into kind of an AI generator, and you kind of see what comes out of that, and then you take a physician and be able to apply kind of that art of medicine, right? Because the computers are only going to process the inputs that you give them. But I think the benefit of this kind of AI technology is it's going to really evaluate the likelihood, the symptoms. So yeah, your symptoms might describe some, rare mosquito-borne virus that has, 2 cases in 100 years, but it's going to give an indication the likelihood of that is exponentially low, right, versus any one of these other things that it could be. You then have that as a framework, not as a driver, but you have that as a framework that as the patient, then you take that into your doctor and say, I put in everything that I've been going through. When I went and, saw my family care doctor, they had me do labs. Here were my lab results I plugged in. This is what it gave me as kind of a framework. The cardiologist or electrophysiologist or vascular surgeon, whatever, can look at that information and say, okay, well, here's the symptoms I'm seeing. Here's your report. And now kind of what separates us, I think, from that AI modeling is, yeah, the AI modeling is going to run those infinite algorithms of statistical equations. But the thing that's interesting about healthcare is it's people driven. And again, people aren't machines. And I think I don't think there will ever be a time where good medicine is AI driven. I think there is quickly becoming a time where medicine will be AI informed. And I think that's what we need to be prepared for. And honestly, that's what I would really drive even people that listen to this podcast to get on and explore the different AI platforms. And if you're having concerns about what a condition may be, don't use WebMD, right? WebMD forces an output based on a limitation of certain inputs that you can give it. But AI can take some of that unclear information and really drive results. Again, that shouldn't be I must have X or I must have Y, but I think it's a good outline to take into your provider and say, here's just kind of what I'm seeing. I plugged these into the generator at midnight last night when I couldn't sleep. I went on the portal and I got my lab values. I got my stress test results. I just put in, here's what I was experiencing and about how long it's been going on. AI is going to give you a reasonable range of things to consider, and maybe even some things that a provider, whether it's a specialist or not, isn't going to be able to recall every symptom of everything that they need to consider. If they have a list that's broken down, it gives them a much more focused way to then narrow down what the actual result is. And I think you're going to see a lot of innovation in that regard too.
Yeah. Oh, I mean, I couldn't agree more. And I think one of the things that, I hope will happen is that, one of the big complaints I've heard from providers that I've sat down with, some of these physicians are like, it's a slog, I'm seeing all these patients. I've got very little time with them. If they don't fit into a particular bucket within the first 5 minutes of talking to them, like I'm running out of time. And the whole idea of spending a lot of time with a patient, is a bit of a thing of the past. It's just not very common anymore. Yep. And one of the things that I'm hopeful for is that AI is going to, one, take off some of the documentation burden, potentially doing it for them with supervision, and then also some of the Q&A that conversation where it's kind of driving all these questions to kind of come in and try to formulate kind of the beginning stages of putting together a diagnosis, so that clinician has a lot more ammunition and the psychology of it comes into this even more so, because as you pointed out, and we had this especially in the cancer conversation, a lot of times people aren't 100% not only accurate, but sometimes honest. And, they're not honest with themselves. They're not honest with that clinician and that sort of thing. It's not malicious. It's just, there's a lot of things going on psychologically with that individual who's terrified. They may not want to know what the answer is. And they just want somebody to tell them there's a quick, easy answer that they can take care of and walk away. And sometimes when they don't get those answers, they'll go to the internet and influencers and whatever. They'll go to social media and they will seek out the answer that they think fits them, whether it's misguided or not. And that's the thing about what we want to try to do in this podcast, is to really kind of bring all those things to the surface so that people are like, okay, be careful out there, because there's a lot of misinformation. There's a lot of people pushing things that aren't going to help you, that are outside the medical system. As flawed as our healthcare system is, and we can all admit those things, there are a lot of really, really great things about the American healthcare system. And I'm hopeful that AI is going to play a key role in really supporting our clinicians so that they can go back to why they became clinicians in the first place.
Things that really kind of get me inspired. Like this is what I nerd out on, and this is what I really kind of challenge my team with. So there's a picture that I have, and I think this is indicative of kind of where AI needs to take us in healthcare. There's a picture that I have on my bookshelf, and I'm a huge Civil War guy. I love the Civil War. Shameless plug for the Ken Burns Civil War documentary. I've watched it through about 10 times. I love that thing. But the picture that I have is of the Confederate States, the Merrimack and the USS Monitor, the first two ironclads. So I'm going to nerd out a little bit here, but the background is that the South was they first kind of put these iron plates on what was then called the Merrimack, and it was something that had never been done before. They were the first ones to do it, and the North really kind of got worried that how are we going to, counter this? They didn't really know what it was capable of. Well, a little while later, and, several weeks, months, whatever, the U.S. Navy had a blockade around the southern states, and the Merrimack just goes right out next to, I think it was the USS Cumberland, and the Cumberland starts firing its cannons, and they're just bouncing right off the iron plates, right? And the Merrimack gets right next to the Cumberland, opens fire on the cannon, and sinks it in shallow water, and goes right up and runs the USS Minnesota, I think it was, aground. And this one ironclad just went through the naval blockade that the North had in place and just completely annihilated it. Got dark, and then it kind of went off. North got really worried. They thought, man, this thing is going to come right up the Potomac River and it's going to shell the White House. I mean, that's how close the Potomac is. We got to do something. So they reached out to, in their mind, the one person that could help them. He was a Swiss inventor. And the joke on the documentary is that he was actually mad at the Navy because he had done services that they had, in his mind, not paid him for. But after they kind of showed him the dire situation that they were in, he agreed to help them. And from the time that he agreed to help them until the time the USS Monitor slipped into the East River in New York City, it was about 1 year. And he created a ship completely made of iron. Instead of a whole wall of cannon on its side, it had one turret with only 2 guns on it, but the turret could rotate. And what I love about this story is from the moment that that ship was created, there were 47 patentable inventions on that one boat.
Wow.
And it took a couple weeks, but the Monitor finally made its way south and encountered the Merrimack. And newspapers at the time were, as good as slow shutter speeds could, were capturing kind of pictures from the land of these 2 ships fighting. And they basically got in so close, they were bumping into each other while they were fighting. The cannonballs just flying off these iron plates, neither ship sunk. And the idea here, and the newspapers were kind of reporting that, that Europe was kind of watching and reading about this play out. And in the documentary, it talks about with this kind of horde fascination. And the tagline kind of in the documentary that has always stuck with me, and the reason I got this painting, is it says, from the moment that these 2 ships went to battle, every other navy in the world was obsolete. Wow. And I think that needs to be our approach in healthcare is, as soon as we can understand, the faster that we can understand how to leverage AI, the departments, the specialties, the healthcare systems that learn how to do that the fastest and in the most responsible way possible will make every other health system obsolete. And I think that is, when I talk to people about what gets me up in the morning, that does.
Yeah.
Like getting up and doing the same thing this time that I was doing this time last year bores me to death. I want to come in and say, good, it's a Wednesday. What are we going to innovate today?
Right.
Now it's a Thursday. What are we going to innovate today? And as the service line leader, that's my charge, right? I've got people that lead the day to day. My thinking needs to be 12, 18, 24 months in the future as to how we can innovate and do these things. So, I'm working with, special analytics companies that work on how to, increase efficiency. I'm, taking classes and I'm doing online education on how to utilize AI in business and healthcare spaces. Again, I think the people that learn how to do this responsibly and the most quickly will make everyone else obsolete. And that's my goal.
I love that story, by the way. I'm a big history fan myself. But, in that particular situation, those were 2 governments that funded that innovation, right? And so now in today's environment, there's a little concern because the downside of having to innovate is failure. How often can you fail? Because there's money tied to that failure. Right. And so having, backup and support to push that innovation forward. Is there any concern in our current environment that funding is not going to be there for a while?
I think there has to be, right? I mean, I think there has to be some level of unease about using the funding and really tying it to innovation. But to me, that's where the excitement starts, right? It's, what I tell my team is anytime I have a new employee, whether it's a new manager, new supervisor, I tell them your only job is to fail forward. And so I think when you tie funding for innovation on the idea of it's either pass fail, then you'll never get an ROI. The story of the invention of the light bulb, right? Is, I didn't fail 1,000 times. I just found 1,000 ways to not make a light bulb.
Right.
As soon as you find the one that works, you've got a world-changing innovation. And I think that's, if we looked at it and said, well, you either find a way to make the light bulb or you don't, well, 1,000 times we didn't. And so if you just stop working on it, how long till we have a light bulb? But we keep going, we fail forward, we get a little better each time. And in that sense, I think you can see the progression of, whether it's government or private equity funding for innovation. I think there has to be a long-term vision for any innovation. If innovation is you've got 6 months to figure it out, pass, fail, there'll never be innovation, because people won't want to risk their reputation or their job on something brand new that is tried, that if it doesn't work in 6 months, they're out of a job.
Right.
But the idea that, we will continuously work towards innovation to get to this goal, then if you can take a 5-year approach to it, I think you would see people be more willing to leap into that innovation space.
I'm fairly optimistic about it. There's a part of me it's a little bit cloudy for me, because, when you're talking about those industry reps that are coming in with those new innovations that a lot of times they're not always saying, well, this is because, there was a government study and that, there was other things going on behind the scenes that helped us, get us to where we're at right now, so that we could invest heavily into this, because it was already proven over here in I don't want to say safer environment, but I mean, the environment is, when you're talking about, a government kind of supported research, that sort of thing. And that has a pipeline, and sometimes it's a very long pipeline. And so when that stuff starts to choke off just a little bit, you start going, well, what's that going to have on our 10-year vision now? Is that going to slow things down? Are there other countries that are going to outperform us and out-innovate us? Not that that's a bad thing necessarily, but it's just, as America, you want to keep your own innovation strong, and especially around healthcare and that sort of thing.
Yeah, I think that's one of the things that has really set American healthcare from a lot of other countries. And again, I'm not going to take us to a direction of one system being better than the other, but the benefit, I think, of the American healthcare system has always been, it's always going to have the most up-to-date innovation, the most up-to-date, ready-to-use technology. And I worry that we've created a climate in healthcare in America right now where that innovation has been so sectioned off or privatized, however you want to say it, to where the companies that are innovating are the ones that are working on a 15 or 20% margin, and they're selling it to healthcare systems operating on a 2% margin.
Right.
And on some level, you're going to create a situation where there's these game-changing innovations that no one can afford.
Right.
And I think we have to get into, more, whether it's government or, some other system of innovation where it's not just, these for-profit companies that are beholden to shareholders and, and profit margins. It's not a critique on whether that's good or bad, but, most healthcare systems are operating anywhere between 1% and 4% margin a lot of times. Some a little bit higher than that, but for the most part, you've got your academic medical centers that have a little bit different revenue stream and everything else than others do. But for the most part, your bread and butter hospital systems across the country, from Maine to California, if they're not an academic medical system, they're probably operating on a 1% to 3%, 4% margin at most.
Yeah.
And when you've got a 20% margin for-profit company saying, we'll buy this, we'll sell it to you at the rock bottom price, that's still a lot of money for that system to invest. And so it creates a lot of stranglehold on innovation.
When you look at a healthcare system as a business and you're like, okay, what are the things that drive procedure, and we could like go down a rabbit hole with, you've got drug reps out there that are pushing certain medications and they're pushing certain studies that were done by the pharmaceutical company, and that sort of thing. And so in another side of it, you've got the insurance company that's sometimes pushing medicine in one direction, and then you have the for-profit companies that are pushing it in another. And so then it aligns with if a procedure is more expensive for a healthcare system, is it less likely to be used than one that's more profitable?
Yeah. So I think what you generally see when you've got procedures that are only profitable in bulk, or that just aren't profitable in general, you'll either see healthcare companies move away from offering those procedures, and you end up with usually kind of a couple, quote, centers of excellence, where basically they become the end all be all for that particular thing. And in doing that, that gives them a little bit more of an opportunity to negotiate with the insurance companies, because, there's, and I'm just example here, but there's 50 hospitals in the state, and all 50 of them aren't doing this because no one makes any money on it. So now there's one hospital that kind of becomes the place to get that procedure done. Nobody else is going to offer it. So now that hospital can say, well, we're going to negotiate the rate of this procedure because your customers can't get it done anywhere else. Yeah. So we have a little bit more leverage to control the price of that. And then no one else is competing for that, and therefore no one else is losing margin on that. Honestly, I think that's a terrible way for the patient, because you're creating a system where in order to get a particular procedure, patients are driving all over the state, all over the country, for
sometimes all over the world,
mm-hmm. for a certain thing. Mm-hmm. And so I think that's a big downfall of having procedures that are not appropriately compensated, whether it's through insurance or just the cost of offering the procedure. And so I think that's a big issue. And, you with the drug reps and stuff too, is I think we see that same issue kind of with medication, right? When a new medication makes it to market, I believe they have a patent on it for 20 years before there can be generics, which really allows them to control the cost and everything else. And, aside from certain kind of medication, programs that will allow patients kind of extra money to afford a particular medication, you're really kind of beholden to what the drug company says. And we are one of only 2 countries in the world, at least last I checked, that allow pharmaceutical companies to market directly to the consumer. Mm-hmm. So you can't do that in other countries. Mm-hmm. So the idea of going into your doctor and asking for a specific medication isn't a thing other places, but it is here. And again, I think that creates its own problem, right? Because then you've got drug reps, and I've known many drug reps. They're very nice people. They're doing their job. But when you look at the margins of these companies, you look at the margins of the people actually offering the service. And I mean, we've got drug reps calling my clinics every day of the week, asking if they can bring coffee in the morning for everybody and lunch, or wanting to do special events where they're going to take the physicians out for dinner at the nicest restaurant in town and order whatever you want, however much you want of it, and they pay the bill, which again, my physicians appreciate. I've been to a few of those meals as well. I really like to try new restaurants that I would never pay for myself. I appreciate that. And I realize the hypocrisy a little bit of saying, but the problem is they're doing this for multiple places, multiple days of the week, and they're one person with one territory, and that is replicated over and over and over again throughout the entire United States. And then my patient needs a life-saving medication. There's no drug company, there's no program for it, and it's $500 a pill. Mm-hmm. That $500 a pill that they're paying to save their life is paying for them to bring my team Olive Garden, right? You just have this hard time making that make sense in your mind. I really like my team, but they could do without Olive Garden a couple days a week to bring down the cost of that medication. That's always kind of rubbed me the wrong way. And so
Sure.
it's not a dig at individual, pharmaceutical reps. Like I said, I've known many, but the system that we have set up
Right.
proliferates this problem, and I don't think creates a fair environment for the patient who has to decide, all right, well, am I going to take this medication, or am I going to have, this vascular, hardening issue that's going to ultimately lead to the loss of my leg? Like, well, maybe I could take a half of a pill and just delay it a little. Like,
Yeah.
these are the decisions that our patients are making. And I think that's an environment that's unfair for the patient to shoulder the responsibility of, if I don't take it versus do I take it? And so,
Yeah, but I mean, that's the whole point of this podcast, is to bring these things to the surface, because a lot of people don't understand that there's this whole cottage industry going on behind the scenes. You have physicians who work directly for the pharmaceutical companies that go to different, events that the physicians are going to get training and that sort of thing. And they have research that's really driven by those pharmaceutical companies. So you bring that up. It's really, really good. One of the things I was kind of caught my attention while we were talking, because we were talking about, someone having to go somewhere else to get a procedure done, wherever that is. And, I noticed, and this has been, I don't know, probably 15 years ago, that there are certain states in which procedures are less, if you had to do a voluntary procedure, cash out of pocket. And I was really struck by that. One of them was up in Nebraska, for instance. And so I was really curious why that was. And what I found out in the research, and I don't know if it's still the case today, because this has been a long time ago, but they had capped the malpractice settlements that were allowed in the state. And they said that had a huge impact on a lot of overhead cost to the systems itself, to the physicians themselves, and to their insurance and that sort of thing. And so it directly impacted voluntary, well, at least in that side of it. And I don't know about the insurance side of it, but do you guys ever look at like competition in surrounding states and go, is there a competitive advantage that they have?
So I can tell you, in particular, I don't, but we do have individuals in the organization that look at regulatory affair issues, that look at that deal directly with politicians to work on bills, and they would be very aware of any sort of legislation in other states surrounding us, that could potentially have an impact on us. And then again, we do have kind of our insurance team that, we do have the health plan, right? So CoxHealth has the health plan, and their job is to really be informed of any changes that are going on nationally, what trends are happening now, what trends they think will happen in a few years. And so me personally, I'm not aware of that until they bring that to my attention. So, but yeah, we do have people that are constantly monitoring that. So,
do you have staffing challenges with a lot of the older nurses are starting to retire now? Not as many are coming in. We're still in the mid baby boom wave. We
have actually, I think, been more fortunate than most. And maybe I'm only speaking from my service line in particular, but I know that we get kind of a regular report out between all the different service lines, and our turnover percentage has been relatively low. Like everyone across the country, we could use more RNs, but our ability to hire LPNs or medical assistants, MAs, we really created and beefed up an MA training program where we would get people that may be within our organization or in other places around Springfield and the surrounding areas that were not in kind of licensed medical positions, like they were just kind of in entry level positions. And if they had an interest in healthcare, we really grew that program. And so, back in 2020 when COVID hit, we could not find certified medical staff, whether it was RNs, whether it was medical assistants, we could not find them. And again, that's what necessitated the creation of this program. Is turns out when people are aware this is an option and we create a pathway to remove the financial burden, people have a lot of interest in this. And so we're at a point now where we are able to really staff up our clinics and provide our physicians and our nurse practitioners and PAs with medical assistants that help them kind of do the job. And then as a kind of corollary to that, we're able to supplement that with oversight from RN. So kind of in the same way that you might have a physician that works with a couple nurse practitioners or PAs in order to take care of their entire panel of patients, we have a little bit of that same idea where you've got our medical assistants, and then we've got between RNs in the clinic and then directors of nursing, nurses that will kind of oversee that. So any clinical issues that arise, they can kind of help take care of that. But just for that, 80% of the day-to-day work or more, the medical assistants are able to take care of. And so staffing wise, I feel like we've actually been in a pretty good place as far as having the necessary teams to take care of that. And then in addition at CoxHealth, right? So we're part of the Healthcare Alliance that was announced about 18 months ago now with OTC and Springfield Public Schools. The whole idea there is not only to have programs for, RNs and MAs and things like that, but there are so many other healthcare jobs, echo techs and, nuke med, individuals and x-ray and all these other things that, maybe for people that don't want to go to college, that, with a 2-year training, you can get a very, very good paying job, doing this thing that speaking, a little bit selfishly from a cardiovascular standpoint, as we have more and more physicians that we recruit and hire, our need to have more and more people that can do these images goes up. And so having this kind of built-in training ground that we've got between all these other academic institutions allows us to really be proactive in targeting students finishing high school, interested in starting into a career without going to college, or you've been to college, you're interested in kind of looking at a different spin on a career. Here's a place we can get you the training you need quickly. And that's been a huge innovation for us to talk about. I'm a big part of Leadership Springfield, and the Healthcare Alliance comes up pretty much every time we have a class going through Leadership Springfield to talk about healthcare. This is a really big deal, and it's been very publicized. It's kind of drawn national attention as a model for other places to really replicate. So
yeah,
we've also again, speaking of technology, we've taken advantage. We were one of the first to prop up a virtual nursing program, and so we've now developed a huge team that does this, that helps us deal with nursing numbers, helps us keep eyes on patients, and CoxHealth won national awards for implementing this as well. So I think that's leveraging that technology to really provide. Do you need a nurse in the room all the time when the patient's asleep? No, but on the chance that they're asleep and they wake up with an issue or chest pain or whatever, or they, pull out an IV while they're asleep because they're turning to bed and they don't know, we've now got eyes on that, and we can alert that instead of, we found them 3 hours later and they hadn't been getting their medication. We can now see that. And so I think that helps us provide that care in between all those moments when it's urgent, but just to constantly kind of have eyes on patients. So it's that leveraging of technology that's been really great.
Our conversation with Dr. Curtis Mattson will be continued in part 2 of this podcast. Stay tuned. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company Elder Care in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.